All right, so today should be a lot of hands-on practice. We're gonna get mostly. We're gonna finish. I think we're gonna finish our electrotherapy for pain management. We'll look at IFC and Premod today. Any questions about TENS? Nothing. Everybody's an expert at it now. We're not going to use it because we read that one case study. Did you say you had something? Because it's uncomfortable. You don't like TENS because it's uncomfortable to you. All right, you're gonna love IFC. Exactly. That's what I wasn't. Did that sound sarcastic? No, I think you're gonna love IFC. Yep.
What are the parameters for like acute versus chronic?
So acute versus chronic. If we wanted sensory analgesia, we could use acute or chronic. The sensory analgesia settings we could use. For the opiate liberation, it makes more sense for the chronic pain, although sometimes the patient's life will dictate that setting more than the type of pain. So if it's chronic, it could be either. If it's acute, it's probably going to lean towards sensory, although there's some room for clinical decision making in there. Okay. All right, so IFC, invented by Dr. Hans Nemrick. Good for him. Ideal for pain that's felt at deeper level than TENS can reach, and can also treat a larger surface area. So the penetration depth of the electricity is just a little bit better. We'll see some diagrams about that. And it is more comfortable. We'll look at why in a little bit. So the big reason why IFC is more tolerated by our patients than things like TENS is because the IFC is delivering its electrical current at way higher frequencies than TENS is. There's an inverse relationship between the skin resistance, that impedance, that resistance to electrical current. There's an inverse relationship between the frequency of the electricity settings and the skin resistance. So when we had our pulses per second on the opiate liberation way down low, it was between 1 and 5 pulses per second. Did you guys feel like you had to really ratchet up your intensity, ratchet up that dial to get that stimulus that you needed to, versus when we were at the sensory, we had way higher frequencies, we didn't need to ratchet up? Does that sound familiar to you guys? So that's just because that the lower the frequency, the more the skin resists the electrical charge. So what were the sensory pulse per seconds? What was the hertz for that? It's up here somewhere. 75 to 100. So in our IFC, we're going to be between 1,000 and 4,000 pulses per second. So it's going to be, we're going to be able to deliver a charge. And I know you guys that have been in the clinic, how many times have you had patients that just say, I don't feel it, I don't feel it, right? If we gave them a TENS, they'd say, I don't, I turn the dial all the way up, I'm not getting what I need to. So the IFC is going to be really helpful for us because of that. So this is a little chart just to highlight the differences in frequencies. At 50 pulses per second, their skin resistance is 3,200 ohms. And at 4,000 pulses per second, it reduces to 40 ohms. So basically, it just means at higher frequencies, it penetrates the skin way easier. That's all that's the take-home message. We said it a few times. I hope it's well understood at this point. So IFC has 2 different channels to it, 2 different sinusoidal currents to it, delivered to the same treatment area with different frequencies. The carrier frequencies are at 1,000 pulses per second or higher. I think the parameters that I have is either 4,000 or 2,000. But there's a slight difference between the two frequencies, and that slight difference is going to cause the collision as those channels meet in the middle. And that's difference is that interference is going to be the thing that produces the effects that we want. So it's that difference between the one channel and the second channel colliding is what we call is a beat frequency. So if I had channel 1 at 1000 and channel 2 at 1080, the beat frequency is 80 pulses per second. That's the difference between the channel 1 and channel 2. And as they collide, that's what's going to, the body's going to start feeling or responding to. So it's based on the treatment goal, regardless of the form of electrical stimulation, regardless of the frequency or beat pulse rate. It's really great because we just get to be nice and comfortable, and then we get to use the pulse difference to create the effect that we want. So we have a few different things we can use IFC for. Most commonly, it's for pain. Second most common, edema. Third is muscle contraction, better for muscle guarding to try to alleviate that. There are some other forms that we can use for muscle strengthening that I do think are a little bit better that we messed around with last week as well. So again, I just want to make sure we understand that the longer the pulse duration, the more the shorter the pulse duration, the more we're going to be on the sensory side. The longer it is going to be on the motor side. And then if we allow it to stay for a long time, we're going to create some pain. The big thing for this additional safety factor, in addition to all of the other safety factors that we have, with IFC, we don't want to use it transthoracically. We don't want to use it across, and that should be for all of our electrical currents. We don't want to use it through the chest, and all of my electrical currents, I stay away from the heart. Shoulder's fine, neck is fine, right over the heart. I think we can skip that. I think we can find something else. But there is some challenges for us with penetration depth, especially if we want to get to the more edema type process that we could use for this. So we're going to be crossing our channels. That's a little bit of a challenge for IFC. IFC, the downside is we need 2 channels, we need 4 pads, we need a big enough area that we could, configure that, or small enough pads. But what's the problem with smaller pads? It can break easier. Okay, that's a good thought. What else? So there's more resistance with a smaller pad. So that we get to some just area trouble. But hey, we're smart people. We'll figure it out. The bigger the pads, that was the maybe you fell asleep this before, maybe the AC/DC reference that woke you up. When the example, the analogy the textbook used was, if you want to enter a house, would you rather go through the window or the door? So the bigger the area, the easier the electrical current to go through. So the smaller the pad, the harder it is to deliver the electrical current. And I think if we were to also use, I think our textbook used a lot of water examples. So if you wanted to put out a fire, do you want a really big hose or do you want a really small hose? Well, the bigger the hose, the more water can go through. Not clicking yet. Yeah, I get it. I get what you're saying. Great. I'm going to, whenever you email me, Michelle, I'm going to email Mary and say, can you translate this for me? Because I'm having a little trouble. Great. So what was I going to say about this? Two channels must be used. They must be crisscrossed. Current follows the path of least resistance. So again, it's important for us to use things like motor points when available, acupressure points, trigger points. Those will conduct the most electricity, have the decreased impedance. The contour of the body will also matter. So especially if we do things like around the quad, you know, we could really contour this, and you can see in this diagram how much we can penetrate the depth of this IFC and the beat frequency, and versus if everything's a little bit closer together with less of a contour, we're going to be more superficial. So yeah, it's a little bit more abstract than our laser and ultrasound. Laser and ultrasound, we took a tape measure and said, okay, look at your patient's tissue and see, you know, estimate that tissue depth. Is a little bit more abstract, but something for us to think of. So again, we want two channels crisscrossing the area they intersect. In the middle is going to be the resultant frequency or the beat frequency. So at this carrier frequency is a 4,000. This other channel is set to 3,820. There's an 80 hertz difference. That's going to be the resultant frequency that that center starts feeling. And again, that's either, depending on the settings we use, it's either going to be for pain, edema reduction, potentially strengthening as well. Use windows, not brick walls. Again, use the area that's going to accept electricity the best when able to. Although that's probably really important for our modality like a TENS. With IFC, because of the carrier frequencies, we can ratchet up the intensity pretty good. But even with IFC, we've had patients who say, I just don't feel it, and we just keep spinning the dial, and so we can't go up anymore. So I think in those cases, we'd really say, okay, turn it down, really analyze the locations of your pads. So two channels, each channel is a line of current. The third line is the intersecting line. So that's one of those things in a textbook or an article you might read, the third line of current. Well, there's not a third line. We have two channels, channel one, channel two. The third line is that the point they intersect, and that's a little terminology thing you might come across. Now, if we look at this guy, way back in the fourth or so slide of the PowerPoint last time, I said that there might be an advantage to mismatched size pads because of the difference in impedance. And I'm not sure if this patient is using different size pads because of an advantage of that, or if it's simply just the area that they're trying to get. Maybe the 2x2 squares just wouldn't fit at those suboccipitals as much as well as the little dots are. So something for us to consider. So kilohertz frequency under the electrodes of each channel are so rapid they are incapable of eliciting a specific motor response. Nerves can only carry impulses at their clinical induction velocities. So in order, the nerves need time to repolarize before another impulse can be carried. So because the frequencies are so high, we're not going to get one sustained contraction like we would with some of the other settings that we played with for muscle strengthening. So here's some of our parameters. So carrier frequencies, again, shorter duration, phase, more comfortable, less likely to elicit a motor response. At 4,000 hertz, we have 125-second microsecond phase, more sensory. At 2,000 hertz, we are going to create some form of muscle contraction. But the beat frequency is the thing that we really want to mess with. Higher is going to be more comfortable, lower is going to create more of a muscle contraction. So the beat frequency for pain reduction is going to be between 70 and 120 beats per minute. Edema reduction, beat frequency, we want 50 pulses per second or beats per second or hertz. And for muscle guarding, we want it 80 pulses per second. Now, we talked about the sweep settings and vector scans. The sweep setting is going to prevent accommodation. So that accommodation, do you guys feel with TENS after a few minutes, you felt like I could ratchet it up a little bit more, right? So that's the accommodation. That's the body just getting used to it. With a sweep setting, it just varies that second channel slightly so that we reduce the chances of accommodation. I know, Annie, we had talked about at work, if you're gonna mess with the sweep settings, because you said you can think of a few patients that always accommodate to it. Did you get a chance to try that at all? All right, yeah, see, check with the therapist just to make sure you can mess with it. Hey, can I try this sweep setting? They're probably gonna say, what are you talking about? You want to sweep? Oh, go, the broom's over there, you know. But yeah, see if you could, if it's okay with your PT that you're working under, can I try the sweep setting and see if that person doesn't complain? It'd be interesting to see. But yeah, the sweep setting's really good. I don't see a reason not to use a sweep setting. If I'm going to be doing an unattended e-stim, the benefit is I don't have to be there. If I just have to press that button and now the patient's not going to call me over 5 minutes, I can't feel it anymore, then great, I can do whatever else I want more. Like that's the big benefit of unattended e-stim is I don't have to be there. And then the vector scan is just going to change the amplitude of the second channel. The higher the percentage, the more broad area that's going to be covered. So if we were going to look at the diagram here, if I put the vector scan on, this X in the middle, the green X, that's what the target area, that's the area that the beat frequency, the difference is. All it does is it makes that area bigger. That X becomes bigger. So one of those things that if you have a patient with a really large area of pain, maybe you dip into that. I've never experienced a big difference with that at all. The scan settings, I'm sorry, the sweep settings, yes. I know I've had patients that have bothered me less when I put that on. The vector scan, I can't say that I've had great benefit for us. So it's something for us to play with. All right, so here's some quick or one-page recap. Here's what I want to try. I want to get at least one perfect rep. Remember, our perfect reps are supposed to be exactly that. Perfect. Good education, good contraindications and precautions reviews. Make sure our patients understand their expected experience. So get some perfect reps, good skin screens, get our perfect reps. After that, you can get some quicker reps, but I want reps on a few different body parts. So make sure we can do at least cervical, shoulder, low back, hip, knee. I think ankle probably should go on there too. I think especially, I mean, these are broad, but I think maybe, SI, left SI might be a nice low back one versus, broad, it hurts all the way over here. So you can be even more specific, anterior shoulder versus posterior shoulder versus the entire shoulder. We can be even more specific than just this list has. So I'm going to challenge you to what I'm hoping we can do. One, perfect reps are always good. Two, let's troubleshoot pad placement. That's the next thing that we've got to start troubleshooting. Where do I put this pad? And especially one thing I was saying, I forget who I was saying to last week. With women's fashion now, with the tank tops and sports bras that have 1,000 different zigzag straps moving in every single direction, there are plenty of times I look at my patient and go, how the heck am I going to put a pad in? Where do I do it? And do you guys at work that put on and take pads off all the time, do you guys sometimes go, where is this pad? How do you even weave this in here? Do you guys go through that all? It's one of my, I don't experience a ton of anxiety in my life, but that's one thing that I go, oh, what? Yeah. You need a putty knife. You know what a putty knife is? I'll grab one from home. Yeah, you shouldn't use a putty knife on your patients. That was a joke. All right, so enough with, I'll come up with my stand-up bit in a little bit. We'll go through that in a little bit, but why don't you guys start practicing this? So make sure we're getting different locations. And if you're feeling really good, also start adding ice and heat with it, okay? Any big problems? Any troubleshooting we had to do?
We used it for my ankle. To try to figure out the placement of the pads, and to change it from, it went like underneath my foot and then we moved it a little bit around.
Yep.
And it felt like it was getting more of the ankle after moving it.
Okay.
Cause I've seen the way he had it like, it was like underneath the foot, on top of the foot, and then like here and here.
Yep.
Yeah.
Yep. And you had a problem with pad location as well, right?
Yeah.
Yep. So that's great that we've already had some troubleshooting of, okay, what is the setup that I want? Remember with IFC, X marks the spot. So we want the middle of the two channels where they intersect. That's my treatment area. So it's not underneath the pad that I want them to feel it, although that's the sensation is what they're going to feel. The treatment area is in between all of the channels, all of the pads. So that can make things, tough to figure out. And what you said was I felt it under one pad, but the other three, I didn't feel it in. And then that one pad was so sensitive, I couldn't adjust the intensity anymore. We were on probably either a motor point, trigger point, or acupressure point. So that if I move that one pad, I have to make a decision as a clinician, move that one pad off of that point so it's similar to the rest of the pads, or move the other three pads. That one pad is on a window, the rest of them are in a wall. So I can either move the ones that are in a wall to a better spot, or I can move the one pad into a different spot. And so that's up to us as a clinician. So some of the other things that I want to make sure we know how to troubleshoot. We always keep this in the back of our mind, because it's never good enough to say, I don't know what to do. So the first thing, do we want to warm the tissue ahead of time? Does our patient need that? You'll figure this out after the first visit, after you do the rest of the steps. The next visit, oh, this guy always needs heat first because he has high impedance. The pad size appropriate? Do we need larger pads? Clean the skin ahead of time. The pad location, like we were just talking about, finding those windows. What's the problem with adipose tissue? Adipose tissue increases the impedance. So the more adipose tissue we have, both the person as a whole, but also just the one location too, that could be something to consider. So do we move it off of an area with higher adipose tissue? I'm thinking mostly in the hip area, hip and glute region. I think that might be a consideration. And then the one thing that I have an idea on, but I don't have any research, is the patient dehydrated? If the patient's dehydrated, what do we know about hydration and electrical current? It's going to increase the electrical, it's going to decrease the impedance. So yeah, maybe we don't talk to our patient, our early morning patients, they only had a cup of coffee and they came here. Maybe we have to talk to them about having some water in the morning before their appointments, potentially. That's just a little thought for you. Do we have any questions yet? All right, so Premod or premodulation. So the beat frequency or pulse trains are from the device, from one channel, not two. That current is mixed within the machine. So we only need one channel for Premod, which is nice. Smaller treatment area. Busy clinic, I get to work with two patients with one machine instead of one patient with one machine. So sometimes that's a consideration. You guys that work in clinics, do you guys ever get so busy that you ran out of machines? Yeah. So hey, 5 o'clock's busy, everybody gets Premod. At 11 a.m. when the clinic's empty, maybe everybody gets IFC. Terrible decision making. But so it is not IFC, no interference, because there's only one channel, but our our parameters are the same as IFC. So all of those parameters on the pulse frequencies, we can adjust those. We set them the same as our IFC. So bipolar setup, not quad polar. So why don't we take another shot at this? Let's take another shot. I think I saw a lot of good things. I saw people using hot and cold with their currents. That's nice. We're going to do another round of practice with Premod. Same thing, hot and cold if you want. If we're applying hot and cold in addition to our electrical current, whatever it might be, when do we apply the hot or cold? Before we adjust the intensity. So we would want to put the pads on, then put the hot or cold as secondary modality, and then we can start adjusting the machine from then. What's the problem? How come I don't adjust the machine and then place the pad, secondary modality on? The intensity changed immediately because what are we changing? We're changing the amount of contact of the pads and the skin. So that will, the more contact with pads and skin, the more the current's going to flow. Anybody's pads feeling like they're getting worn already after just a week? And guess what? We got another 2 or 3 weeks of this. So they're going to get even more and more worn. You might want to start using straps to hold your pads in place. That will also improve that interface. So another consideration for you. So I'd like to practice Premod again. Make sure, challenge yourself. Get to tricky areas. Get to the foot and ankle where you go, I don't know how to do this. Find somewhere where you look at the patient and go, I don't know how would I do this? I want help. I want somebody to challenge me to say, how would you do this? So find the tricky areas. If you need to, we got plenty of sheets for draping. We still want to maintain dignity of our patients and classmates. So I know it's been a lot of time spent together. I know sometimes that gets worn off pretty quick, but make sure, even though we're as friendly as we could be with one another, make sure we're still getting in good habits of draping our patients. Okay. All right. Any questions? All right. So another round of practice with Premod now. Okay. And that'll be it for us.